The following podcast is part of a certified educational activity titled Strategies for Appropriate Assessment and Use of APOE Status in Alzheimer's Disease, Clinical Care in Europe. Access the entire activity and complete the post-test at peerview.com/VAD860. Downloadable slides and practice aids are also available.
Hello and welcome. My name is Juan Fortea and I'm the Memory Unit Director of Hospital of Sant Pau in Barcelona, Spain. And today it's my pleasure to be here today with a colleague and friend, Dr. Frank Jessen from the Department of Psychiatry at the University Hospital of Cologne in Germany. And we'll be discussing the strategies for appropriate assessment and use of APOE status in Alzheimer's disease clinical care in Europe. During this presentation, we will learn that APOE genotype influences Alzheimer's disease risk and clinical course and has important implications for safety and treatment response in patients receiving anti-amyloid-targeting therapies. We will also learn that the successful use of APOE testing in clinical practice depends on identifying appropriate patients, ordering and interpreting tests correctly, and integrating these steps across the care team. Shared decision-making with patients and care partners to guide informed decisions about APOE testing is a key component of Alzheimer's disease care planning. Now, I am going to briefly review the clinical relevance of APOE and how one's APOE genotype influences the risk for Alzheimer's disease. Apolipoprotein E, or APOE, is a multifunctional protein with key roles in lipid transport, clearance, degradation, and aggregation of amyloid beta. The APOE gene has three common alleles, epsilon-2, epsilon-3, and epsilon-4, that encode the APOE2, 3, and 4 isoforms. The structural differences contribute to the difference in AD risk. APOE3 homozygotes are the most frequent isoform and are considered neutral. APOE2 is a protective variant, whereas APOE4 carriers are at increased risk. Heterozygotes have a 3 to 4-fold risk of developing Alzheimer's disease, and homozygotes up to 15-fold increased risk. Importantly, there are big geographical differences in APOE4 allele frequency, as depicted in this map. You can see the regions in red have much higher frequencies of APOE4 than the rest of the world. And today we're talking about Europe, and you can see that there is a very clear north-south gradient, such as the countries in the north have much higher APOE4 allele frequencies than those in the Mediterranean basin. As I said, APOE4 is a multifunctional protein, but it promotes A-beta aggregation both in the brain parenchyma and in the blood vessels. It's probably one of the most important drivers of the increased APOE risk for Alzheimer's disease. The insufficient amyloid clearance associated with APOE4 makes it a significant risk factor for both Alzheimer's disease and cerebral amyloid angiopathy. In fact, AD and CAA are frequent comorbid conditions, especially in APOE4 carriers. In this table, we can really see with numbers that APOE4 is a strong driver both for A-beta deposition and Alzheimer's disease risk. If we focus first on the first column, we can see the frequency of the different APOE isoforms. You can see that APOE3 homozygotes, the third row, are the most frequent in the general population. And in the second column, we can see that when we focus in patients with AD dementia, APOE4 is greatly enriched. And over 60% of patients with AD dementia will be carriers of at least one APOE4 allele. And up to 15% or more of those will be APOE4 homozygotes. You can see that in the general population, homozygotes only represent about 2% of the population. This, of course, translates into these odds ratios, this increased risk of Alzheimer's disease dementia. Again, 3 to 4-fold in APOE4 heterozygotes, up to 15-fold odds ratio of up to 15 in APOE4 homozygotes. But in the right of the panel, we have very interesting data. You can see here that in this very nice review, the authors tell us the odds ratio for amyloid positivity at a given age, in this case, age 70. And this is very important. First of all, because when we assess the risk for AD biology, the risk conferred by APOE4 is usually higher than when we are just comparing the risk for clinical dementia with no biomarker confirmation. And secondly, because APOE does not confer the same odds ratio at the different age ranges. In fact, this is due because not only does the APOE4 increase the risk for Alzheimer's disease, but it is also associated with earlier age of AD dementia onset. So you can see APOE4 heterozygotes present symptoms 2 to 5 years earlier than APOE3 homozygotes. And in the case of homozygotes, it is even a greater advance in the symptom onset, up to 10 years earlier than the general population. You can see in the panel a summary of this. You can see that APOE4 homozygotes have a much greater risk of developing AD dementia at earlier ages. Importantly, you can see that APOE4 is dominant with respect to APOE2. Please note that APOE 3/4 and 2/4 are collapsed together, and they confer an increased risk with the APOE3 homozygotes in green, which are the reference group. And again, APOE2 carriers are protected. A very important question is whether race and ethnicity modify the APOE4-related risk for Alzheimer's disease. Because, of course, this has huge implication when counseling patients and individuals carrying the APOE4 allele. And there is a wealth of literature suggesting that the risk for clinical AD dementia is highest in individuals with East Asian ancestry, followed by non-Hispanic whites of European descent, and lowest in non-Hispanic blacks or Hispanics. However, the findings are mixed. And in this figure, I summarized two recent papers that question this ethnicity risk. In the top row, you can see a very nice paper by Claudia Suemoto, recently published in Alzheimer's and Dementia, that showed in the Sao Paulo brain bank with over 2,000 brains analyzed, that the risk conferred for the APOE4 did not differ or was not lower in Black individuals than in those with European descent. And that's, again, pathologically confirmed AD cases in a very diverse dataset, a very unique cohort. And in the lower panel, we have the results from a cohort in Peru with Amerindian descent. And in this study, people with Amerindian descent have even higher risk factor and risk for APOE4 carriers than those with European descent. So as I said, mixed finding with respect to this risk conferred by race and ethnicity.
So Juan, let me jump in here. This is very interesting. What do you think is the reason for these findings in the Brazilian and the Peru cohort?
I think this illustrates a very important homework or knowledge gap in our field. I think that we need to redo a lot of the epidemiology associated with Alzheimer's disease. And this has to be redone with biomarker support. I think that most of what we know is about dementia, clinical dementia diagnosis, and we know that we make a lot of mistakes when diagnosing the patients just clinically. I think that this divergence between the odds ratio when we are comparing biological AD and those with clinical AD diagnosis, I think this is a critical factor to do. So I think that in the future, we need to redo this epidemiology of prodromal AD or MCI due to AD or AD dementia, but with the support of biomarkers. And not only for APOE, which is what we are discussing today, but also for even amyloid positivity and many other things. I think that there is a lot of work ahead of us to really have better calculators for AD risk, and this will be essential in the next few years.
Yes, I thank you very much, Juan. I think this was an excellent overview over the epidemiology, the risk for Alzheimer's disease of APOE, and now we are entering the new era of treatment, and there APOE has a very new role, I would say. So I would like I would like to discuss a little bit about the implication of APOE and APOE gesting now in the new era of amyloid-targeting therapies. So one, or the main or the most prominent side effect of the new anti-amyloid antibody treatments are changes that are observed in the MRI called amyloid-related imaging abnormalities, or ARIA. And there are two types of ARIA. One is called ARIA-E, where there is an efflux of fluids into the brain tissue, which you can see as a hypointensity on MRI, particularly on FLAIR sequences. And there's ARIA-H. H stands for hemorrhagic changes, which are either microbleeds, so the travel from red blood cells into the brain tissue to the walls of the small vessels, or also siderosis, and in very rare cases even larger bleedings, which are potentially of harm for patients. Typically, however, these ARIAs are not noticed by the patient, so they are asymptomatic. They are observed on MRI, but they are asymptomatic for the patient. But they require monitoring and management. And as I said, sometimes there may be even more severe, larger bleedings. What we have learned from the studies is that APOE4 is actually the main risk factor for these ARIAs. So these are the frequencies of the two prominent anti-amyloid antibodies, lecanemab and donanemab, from the phase 3 clinical trials. So on the left, there are the numbers of ARIAs of ARIA-E, first from the Clarity AD lecanemab trial. And the numbers clearly show that with increasing number of APOE alleles, APOE4 alleles, the risk for ARIA-E is increased in lecanemab up to over 30% in APOE for homozygotes. And TRAILBLAZER-ALZ 2 is the large phase 3 donanemab trial, and here we have very similar results with up to 40% of ARIA-E in APOE for homozygotes. And TRAILBLAZER 6 is a modified titration scheme of donanemab, which shows that if donanemab is more slowly titrated up to the final dose, then the ARIA risk is reduced, but still 24% in APOE for homozygotes. Now, these are the numbers for ARIA-H, so the microbleeds and the siderosis, and here's more or less the same picture. So you can see that in the lecanemab study, up to 38% or over 38%, up to 40% of patients in Clarity AD with APOE4, with two APOE4 alleles experienced ARIA-E, and up to 50% in the TRAILBLAZER-ALZ 2 study. Importantly, in most cases, these are asymptomatic, but still this is a very high number. So this has led to some regulatory consequences in Europe. First, in the United Kingdom, the MHRA approved lecanemab and also donanemab, but with the restriction of exclusion of APOE4 homozygote carriers. And the EMA followed basically the same approach. So in both areas, regulatory areas, APOE for homozygotes are excluded from the treatment with lecanemab and donanemab. This is not the case in other regions of the world, like in the United States or in Japan or China, but these are the regulations for Europe. So this means that we have to do APOE genetic testing and counseling in the context of this treatment. And this, of course, then leads to the point that we really have to think about how do we implement a genetic testing, APOE for testing in clinical practice. And what we'd like to discuss now are basically the very practical clinical steps to facilitate the safe and effective use of APOE testing and, of course, also of the new disease-modifying treatments. These are the general inclusion and exclusion criteria of donanemab and lecanemab. First of all, the clinical diagnosis of mild cognitive impairment or mild dementia has to be established. Then there has to be a confirmation of Alzheimer's disease by biomarkers, usually CSF or PET, maybe in the future also blood-based biomarkers. And then the APOE4 testing has to be done to exclude those who are APOE4 homozygotes. And then there are also some kind of some MRI exclusion criteria which have to be tested prior to treatment. And the contraindications are if people cannot undergo regular MRI because this is needed for ARIA monitoring, if there is already some evidence for example, microhemorrhages or other lesions in the brain which may be a risk factor for ARIA, including for donanemab only severe white matter disease or for donanemab only poorly controlled hypertension. And then, as mentioned before, APOE for homozygosity is an exclusion criterion. Also, the use of anticoagulants in Europe and other bleeding disorders. So, APOE4 testing is required in everybody. How does that work? Basically, there are a number of steps which should be followed. So first, there is a pre counseling about. So after the diagnosis of the biomarker-based diagnosis of early Alzheimer's disease, there is a pre-APOE test counseling, which the purpose here is to inform the patient about the general nature of APOEs, as was just discussed by Juan, but also specifically about the risk for ARIA associated with APOE. This is usually done by a dementia specialist, sometimes, depending on the region, also by genetic counselors. Then if the patient consents to APOE4 testing, then there's a blood draw, of course, and they're sent to a laboratory. And then when the result is there, there is the APOE4 disclosure and counseling. So in Germany, I can say that this is usually done by the expert physician. There is usually not a specific genetic counselor involved here in this case. What about Barcelona, Juan? How is it done in your hospital?
It's a very similar scenario. It's usually the neurologist or the primary physician that is informing about the genetic results.
Okay. One thing I would like to add here is that APOE testing is not recommended if a person does not qualify for the treatment because it's not part of the standard diagnostic procedure in Alzheimer's disease.
So thanks, Frank. I think in this slide we are summarizing the key requirements for APOE testing in the European Union. We first should be aware that Europe is diverse, and of course the informed consent process in the European Union varies by country, but it typically incorporates explicit consent form or documented oral consent process. This, of course, should be done under medical supervision and counseling. And it must be emphasized always that this is a voluntary and informed decision. We should inform the patient what is the purpose of the test, why are we determining this genetic status, And what are the implications and potential risks and benefits of the test results? We should also inform about the data protection and privacy, which in Europe are, as you know, regulated by the GDPR regulation. Informing about who will access the data and where it will be stored, and the patient's right to access this data and withdraw consent at any time in the process. We should inform about the family implications. Our patients and the family members, they know more and more, and oftentimes they just do not receive information. They wanted to discuss the information with us, and I think that we need to really cover this topic at length. And of course, at any given time, the patients do have the right not to know. So, Frank, how do Germany's informed consent requirements compare to these general topics?
Well, I think they are just along these lines. And in Germany, we have the regulation that if a patient or a person has symptoms, then there is no specific genetic or counseling required in that sense, that a licensed genetic counselor has to be involved. This is different when, for example, the offspring, the children, wants to be tested, for example, also regarding APOE4, then licensed genetic counselor would be involved for predictive testing.
Yeah, certainly in Spain is the same, and the process is much more strict in people at risk than in those with symptomatic Alzheimer's disease, with very clear implications for the diagnosis and prognosis and treatment, as we are discussing today.
So, what are the important pieces for pre-test genetic counseling in the context of APOE testing? So, of course, the very first step, as we just discussed, is we need to inquire the informed consent. Then we need to explain the rationale of genetic testing in the specific context of the anti-amyloid treatment. That, for example, APOE for homozygosity is an exclusion criterion for this treatment. This is what the patient should know before we do the APOE4 testing. The education on the purpose and value of testing should also clarify that this is not a diagnostic test for Alzheimer's disease, and also does not predict who will develop Alzheimer's disease, also not for family members. As Juan has shown in the first part of this session, there are risks associated with APOE status, but it's not a diagnostic or very specific predictive test for an individual person regarding the development of Alzheimer's disease. Disclosure of implications that the patient's APOE4 status can have biologically children, can have effects on children and siblings, we discussed before, and that they could potentially have negative impacts on family members, and when they know that their APOE4 genotype and their risk. While pre-test counseling is essential, it rarely necessitates referral to a genetic counselor. This is what we discussed before. In Germany, for example, it's only the case if somebody is tested who does not have symptoms. Juan, where can this information be found for other specific countries in the European Union?
I think this is essential because we often refer our patients. All these the reference centers, we do have information at our web pages. We have fact sheets, we have flyers to inform the patients, but we often refer them also to the local or national Alzheimer's Association. And I think that we're in this transition period, and we should make sure that we review the information we're referring our patients to, because I think that the whole APOE testing has completely changed with the advent of these anti-amyloid therapies. And so we have to make sure that the information we're referring our patients to is up to date, because otherwise we can make a very important confusion to our patients. So please check the web pages and the Alzheimer's Association in your local environment to make sure that is completely up to date.
Okay, now we touched upon this a little bit, but we would stress it a little bit more. Consider implications of APOE testing for biological relatives. So genetic testing can lead to family members discovering new information about their own genetic risk. For example, in patients who found to be APOE for homozygotes, it is very clear that the children will have at least one APOE4 allele, and this can affect then the relatives, the children and siblings, maybe affect emotional well-being, life choices, and future planning. And this is why it's important to have a really good counseling, refer family members to specific genetic counseling, and maybe mental health services if they are distressed about the results. However, I must say that there's research on disclosing APOE status in healthy individuals, longer standing research, and this has shown that disclosing APOE4 status to patients and also to siblings and children is usually safe and usually does not cause strong psychological distress. But this is, of course, something to be considered. It's important to be aware that there can be mistakes in APOE4 testing. It has been shown and found in research, for example, that APOE4 tests can reveal wrong results, which sounds a little bit maybe unexpected in genetic testing, but this can occur. And this is why it's very important to use certified labs and also who work with certified technologies and platforms to have the highest standard of quality for APOE for testing, because of course the decision whether to treat or not to treat is a very fundamental and substantial decision. So Han, do you have any experience with these CE marked APOE4 kits which are listed on the slide, and what advice would you give our listeners to reduce the risk of errors in APOE testing in patients in clinical practice?
So I think, Frank, that you did a fantastic summary. I think that the most important point to make here is, again, to reiterate that do not take for granted that there will not be mistakes, because APOE has been with us for a long time, and this has generated a sense of familiarity with the testing, and that we know that in research context we have mistakes in our research cohorts. For instance, we've detected several mistakes in the assessment. Of course, they are not frequent at all, and in research context, oftentimes they don't have these dramatic implications. But as we are reviewing in the context of anti-amyloid therapies, this is essential. So you made it a fantastic point. This has to be CE marked and in very and in the centers with the right experience. And also do remember that the genetic department has to have the custody of the samples at all times. It's not that we can keep the samples in our fridges and send it to the genetic department at all times. Since the blood draw, the laboratory performing the test has to have the custody of the sample. It's not only the determination, but there are no mistakes and misclassifications of the patients.
Yes, and related to this, of course, is the questions of direct-to-consumer testing, which means that people send in their blood or other material to a company, and they receive their APOE results without any type of medical information or counseling or so. This, whether direct-to-consumer testing is allowed or not, is very different from country to country in Europe. So, for example, in Germany, there is no direct to consumer genetic testing available. But in other countries, the regulation may be less. And the point here, of course, is that patients will maybe come with these results to the clinic and will say that I have these tests available. And we advise that if this is the case, the physician should still do a retest with a CE marked lab to really be sure that the APOE4 genotype is correct.
And so now I think, Fran, that maybe we can have a case scenario, no? Because that exemplifies many of the a situation that we are all gonna encounter, or we will encounter a lot in the future. So let me introduce the case of Mateo. Mateo is a 66-year-old retired architect in Seville, Spain. And he has been recently diagnosed with MCI due to AD, with a mini mental state examination of 25/30 and a positive CSF ratio confirming the AD pathophysiology. The MRI showed mild atrophy and no other major findings. And the family did have a positive family history for the Alzheimer's or dementia. And his mother developed dementia at age 65 and died at the age of 75 with advanced dementia. Mateo is highly motivated to start treatments with anti-amyloid therapies, and his clinician informs him that he will need to undergo APOE genotyping to determine his eligibility for treatment. It's important to note that in this case, Mateo's care partner is his daughter, and she expressed concern in the same visit after she learned about the APOE testing, that because of what his genetic test results will reveal about her own risk for Alzheimer's disease. And I think that in the right part of the slide, you can see the key test counseling points to discuss with Mateo, but also with his daughter. We need to ensure that the patients understand prior to testing how the APOE status may affect their eligibility for anti-amyloid therapies. As we've seen, we need to review the legal protections and limitations related to the disclosure of genetic test results. And of course, provide an explanation about what Mateo's test results will reveal about his daughter's genetic risk for Alzheimer's. And as we've discussed, this scenario for the daughter is different and much stricter. And if we might need to refer the daughter to a genetic counselor if she has more questions. So, Frank, what do you think about this case? Have you ever had family members express anxiety about their loved one's genetic testing because they are worried about their own risk of developing Alzheimer's?
Well, not in this particular way. So I have the experience with relatives being worried about their own risk, but if they would know that the parents are, for example, APOE for homozygote, but I've never had that experience that a relative or care partner would be worried about the testing of the patient, him or herself, so that he or she indirectly knows the risk. I think it's very important here to have a very good counseling, as mentioned here on the right side, on the last bullet point, to really clarify what actually a risk is. And for example, APOE for heterozygote is not a very high lifetime risk for Alzheimer's disease. So it does not have to be a very worrisome result which comes out of these testings for this care partner, for this daughter of Mateo. Now, of course, the critical point here is to disclose the results of APOE4 testing, and there are some general concepts of how to talk about risk with patients, which are not specific for APOE, but which also account, for example, for disclosure of biomarker test results. So the language should be plain and easy to understand, and the results should be communicated as absolute results and not as relative results. So, for example, you have the double of the risk, but you have like 10% risk or 20% risk. There are several visual aids which are helpful for communicating of risk. There is also self-directed educational material which can be provided to the patients and which can also be accessed through which are available through several websites. Some examples are listed on the right-hand side. Keep the information focused, avoid non-essential information for the patient. So less is more. Allow the patients to ask questions, of course, so that's very clear, and discuss issues of concerns or interest after the learning of the results. And also watch the patient and address potentially potential emotional responses if there are any. And take enough time for this process. What are the contents of the post-test counseling? So APOE for homozygotes are not eligible for anti-amyloid treatment. For many patients, this may be a very disturbing and disappointing message. It's important to directly say that all other types of treatments of Alzheimer's disease are, of course, fully available to the patient. So symptomatic treatment, all kinds of non-pharmacological treatments, and of course, also the possibility, for example, to take part in clinical trials if available. If an individual is APOE4 heterozygote and eligible for treatment, there is a mildly elevated ARIA risk. However, the monitoring of the patient is the same as in a non-carrier. And of course, it's very important to stress that this patient has to adhere to the monitoring plan of the during the treatment. And of course, it's always important to monitor the care partners and families' reaction to the results. They can be worrisome. They can show some signs of distress. But there are also other cases where patient may actually be relieved that they do not qualify for treatment because they were already not very sure and certain if they really want to undergo this, of course, in a way time-consuming and potentially burdensome new anti-amyloid treatments. So, Juan, is there anything you would like to add to this list?
No, I think that was a great summary, very, very, very clear.
Okay, in your experience, when disclosing APOE for results to patients, have you seen varied responses from patient learning the APOE4 status as being homozygote? And what has been your experience with responses from family members to learning that their loved ones are homozygote?
Yeah, we've had, as you know, we've worked in this space, and we had some publications with some public relevance, and not only that, but we also had people that had undergone APOE testing in other contexts, such as cardiovascular disease, or in other contexts, and that they knew their status, and after that we were talking about the risk for APOE homozygotes, they did contact us to get informed. And I think that's another lesson. I think that the field is evolving rapidly, and while, as you mentioned before, APOE testing is not recommended as of yet in the general population, we will encounter individuals that will ask because they know their status, because they did the testing over the counter or for any other purpose, or because they understand they are at risk because, as we discussed, their loved one or their parents have APOE homozygosity or APOE4 status. So I think this is something that we need to be prepared to discuss with our patients, and this is very important. This is something that will happen to us more and more in the future. And in this slide, I think that this is reiterating a bit some of the message that Frank, you mentioned before, and it clearly shows that the APOE gene dose risk for ARIA with anti-amyloid therapies. As you can see on the left part of the slide, you can see the risk for any ARIA. And in the right part of symptomatic ARIA. And you can see that homozygotes on the left have much higher risk for ARIA than heterozygotes or non-carriers. The good news, and we would like to emphasize more the positives, is that only 3% of APOE for heterozygotes and non-carriers will develop symptomatic ARIA. And this is manageable. And I think that, Frank, you mentioned TRAILBLAZER-6, the modified titration. And you can see, for instance, in the left part of the slide, how how it reduces the risk for ARIA with this more slower increase in the dosing of the NANEMA. And I think, just to reiterate, you made a fantastic point earlier that the anti-amyloid therapies are not the end of the road for our patients. It's not a cure of disease. It's a huge advancement, but I think that we need to offer patients all the treatment options and accompany them in their diagnostic process. And a very key element to that is also to encourage them, at least that's something that we do always in our center, to participate in research. I think that the clinical trials are the treatments of the future, and we are in a region that is particularly active in clinical trials. And in this map, for instance, you can see the wide offer of clinical trials that are active and up and ongoing across Europe. And I think that's another thing on top of the list that Frank reviewed in the previous slide on other things that we can offer our patients.
Now, going back to the practical issue of the ARIA monitoring, so for both compounds, lecanemab and donanemab, there is a very detailed schedule of ARIA monitoring, particularly in the first 6 months, where ARIA are most common. There are a number of MRI scans which are done before certain infusions, and after the first 6 months, there's another one in the first year, and then another more MRIs if ARIA occur. And also there is sometimes a consequence if ARIA occur that the treatment has to be paused or has to be modified. I would not want to go into detail on this slide. You will find that, of course, all in the product information in detail and all appropriate use recommendations.
So the results of the APOE genotyping come back to us, and Mateo's genotype is APOE4 they have an APOE44 carriers. And I think that on the right of the slide, you can see the key points for disclosure for Mateo. In Europe, at least, we should inform him that he's not eligible for anti-amyloid therapies. As you know, this is a particularity in our region. We cannot prescribe these drugs in homozygotes as opposed to other countries. We should provide printed and online educational materials with more information, including community resources and local clinical trial opportunities. As I said, the anti-amyloid therapies is not the only therapy. We need really to accompany these patients to ensure and provide other treatment options, including anticholinesterase inhibitors, nutritional counseling, and exercise. And we can consult Mateo's daughter about her possible APOE genotypes. That, as Frank mentioned, if the father is homozygote, at least she will be a carrier, a heterozygote. And if she wants, we should refer her to a genetic counselor for about the risk to develop Alzheimer's in the future. But what about if he was a heterozygote? Of course, that is a completely different scenario in Europe, because he would be eligible for treatment. And the disclosed APOE results and inform Mateo that he's eligible, as I was mentioning. That, however, that because he has a carrier because of this gene dose risk for ARIA, he has mildly elevated ARIA risk compared to non-carriers. That he needs to adhere to ARIA monitoring guidelines, including 6 MRIs, although that's the case for all patients in practice. And we should, of course, if he initiates treatment, inform about ARIA symptoms and what to look out for, and how and when he should contact the treatment physicians. And we should always provide printed and online education materials. I mean, we're providing a lot of information, and printed materials are essential when advising our patients. And even in the case that they are in anti-amyloid therapies, we should not forget that the treatment plan should be broader. And patients even in anti-amyloid therapies, they should also receive anticholinesterase inhibitors, have the same nutritional counseling and exercise regime. This is good for your brain, and patients on anti-amyloid therapy should also be advised to follow these regimes.
So, to summarize key takeaways, APOE is a key genetic risk factor for Alzheimer's disease. ARIA is more likely to occur in APOE4 carriers. It's most likely to be symptomatic and severe in homozygote carriers. This is why homozygote APOE4 carriers are excluded from treatment in the European Union. All patients who are receiving anti-amyloid treatment or amyloid-targeting therapies, including APOE4 heterozygote and non-carriers, need to be vigilant for signs of ARIA. Patient needs to be educated about these potential signs of ARIA. And APOE results should be used to frame the discussion about treatment's eligibility and safety and weighting the risks and benefits of starting or continuing amyloid targeting therapies. Thank you very much. Thank you for your attention. And now I hand over for the final words to Juan.
No, thank you. It's been a pleasure discussing the APOE influence on AD and therapy with you, Frank. Thank you all.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education, and by the European Board for Accreditation of Continuing Education for Health Professionals. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/VAD860.